Thank you, ma'am. And it's not just a pleasure, but a delight to serve under your chairmanship for the very first time. I'd also like to thank my honourable friend, the member for Warwickshire North, for bringing this important debate to this place today at a very critical time. It's a great pleasure to follow my honourable friend, and that's what he is, an indefatigable member for Strangford. He usually follows me, so it's the first time I followed you, I believe, the member. The lockdown order and the ensuing restrictions that we presently endure have had a seismic impact on the services the NHS can provide, crucially affecting cancer services. NHS figures show a 60% drop in urgent cancer referrals from the initial days of the March lockdown when compared to the figures from the same time last year. Breast cancer now has been mentioned by a number of colleagues, has raised concerns that almost 1 million women in the UK have missed NHS breast cancer screenings as a direct consequence of the pandemic, which were paused during the first lockdown before gradually being resumed. Mammograms have the potential to detect cancer in its early stages and ultimately save lives. Treatment for those with cancer has also been significantly disrupted. The national guidelines may well have stated that urgent and essential cancer treatment must continue, but this has not been the case in every hospital. Not everyone who required urgent surgery has been able to have access, whether this be a result of a lack of ICUs or too great a risk to patient or staff. Similarly, those that require major surgery have not always been fortunate to receive the treatment they need. This again has been a consequence of either a lack of recovery beds with ventilation, no ICU beds if surgery were to have complications, or because surgery was simply too risky. Aftercare has also been disrupted by the lockdown, whether that be palliative care or chemotherapy. The reality of these delays is not only putting women under a great deal of stress and anxiety, but risks making diagnoses harder to treat if caught at later stages. I truly understand this pain. An inordinate number of my family have suffered from cancer. Those who suffer from breast cancer should not be collateral damage in the battle against COVID. Worryingly, this has been the case against virtually all forms of cancer treatments. The Health Data Research Hub for Cancer has warned that there could be an additional 18,000 deaths in people with cancer as a result of the pandemic. In Wakefield, the local NHS Trust, the Mid Yorkshire NHS Trust, has been proactive in their attempts to ensure cancer diagnoses occur and cancer patients are treated. Prior to the pandemic, cancer was already, sadly, the biggest single cause of early death in the district, with breast cancer being the second most prevalent form, with 250 or so new cases diagnosed each year. In May, Pontefract Hospital was temporarily developed into a dedicated cancer centre to care for the people of Wakefield and North Kirklees, who need diagnosis for surgery and suspected cancer during the COVID-19 outbreak. And here I have similar concerns as my honourable friend for High Peak, because the move from Pinderfield Hospital to neighbouring Pontefract was undertaken on the basis that the exposure to COVID-19 in Pontefract was significantly less than Pinderfield's, which is the regional hub for COVID-19 patients. However, whilst I concur with the Chief Executive of the NHS Trust, Martin Barclay, that we are, and I quote, fortunate to have excellent modern facilities at Pontefract Hospital, which is relatively close to Wakefield. For my constituents, having to travel significantly further afield for diagnosis will likely be a behavioural impediment for those scheduled for diagnosis and treatment. This adds to the existing fear for patients entering hospitals, previously evidenced by comments made by Dr. Abdullah Mustafa, a GP lead for cancer care at the NHS Wakefield CCG, who said clinicians working in cancer services know that patients are choosing not to have time-critical cancer treatments because of fear of exposure. In closing, I will simply say that we must ensure that, however well-meaning the policies, that the antidote does not become worse than the disease we are seeking to cure.